Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So again, good evening, everybody. And tonight's class is on sepsis. Okay, I will not be calling it a class on sepsis alone in puerperium or sepsis in pregnancy. I'd rather call it a sepsis as a whole because there are so many important concepts that I want you all to know. You know, what is sepsis? What is the difference between SIRS and sepsis? What is sepsis and severe sepsis? What is sepsis and severe sepsis and septic shock? What is Mu scoring? You know, what is staphylococcal shock syndrome, streptococcal shock syndrome, or the, important aspects of discrete points regarding how to monitor the patient, exactly which antibiotic to be given in which condition, what all conditions to be seen and what all conditions to be taken seriously, when to admit a patient in hospital and when to admit a patient in ICU of the hospital, how to take that decision, how to monitor that patient. All these things I'm going to be teaching in the class tonight. So just give me this 1 hour as I always ask you of, and this topic stands corrected. So you do not have to hunt different books. You can just take out this PPT and prepare this topic. And again, I'm telling you, see, sometimes what happens is the class I've taken on a particular topic, but still, see, no matter how much I try to encompass, there will be some portion of it you will feel that I wish she could have covered this as well. I have no problem. I love, for my students to come back to me, tell me that Pam, this portion also we would like to encompass in your class, and I would love to do it, because even when my notes, they go on to you, you do not have to do anything else. This is the kind of love and response I've got from my students, and I'm so thankful to God that they call me in such a way that you, ma'am, your notes, they are so beautiful. We enjoy studying your notes. You do not have to do anything else apart from just learning those notes. Again, a lot of thanks to Almighty, and a lot of thanks to you, my students, because you are always the reason of me making this class and going on and on and on with your love and your support. So anyways, tonight's class, we're going to start on sepsis. Though I've mentioned bacterial sepsis, is mostly about bacterial sepsis because that is the only sepsis that you can encounter. Tell me, as far as viral infections are concerned, do we have a choice? We don't. We have to go for a symptomatic management for most of the cases. So it's basically bacterial sepsis, which we're going to study. Let's begin. Now, see, severe sepsis with acute organ dysfunction has a mortality rate of 20 to 40%. You understand that means any patient after the surgery, if she really goes into sepsis, especially with organ dysfunction, she runs a risk of dying. Forget about morbidity. I'm not talking about morbidity. I'm talking about mortality. 20 to 40%. That's a huge figure. Rising to around 60% if the shock develops. So this is a very important part because of which we're going to discuss this important topic. Sepsis. Now, I was trying to tell you the difference between sepsis, severe sepsis, septic shock. Sepsis means a focus of infection along with systemic manifestation. Now, I'll ask you a question. Okay, let's start with a chat. For example, you have a sore throat. Okay. All right. Forget about sore throat. Let's talk about some very small thing. For example, you have a wound. You fell down. You have a wound. Wound has got local pus. Okay. You're in pain because of that wound. You're applying your bandage. You're applying the ointment. You're trying to give hot compresses. You're in pain because the wound goes on for 2-3 days, and then it heals. Would you call this infection sepsis? If yes, why? And if no, why? Quickly, guys. I have my students in the class, and this is going to be a little long class because thank you so much. Because it's a very conceptual topic, and I don't want to rush through it. But there are certain things which I really want to know. I want to know the basic. If you know this thing, that whether you call a small infection at a particular site an infection, or you call it sepsis, and why. Okay, tell me if you can call it sepsis or not. I'm there to answer all your queries. All right, I agree. It's not called sepsis, ma'am. All right, let me hear some other few people. Whether you call it sepsis when it's a local wound infection. Okay, for example, a patient you discharged after cesarean section, her local, the cut that you gave, that cesarean incision is not healing well. She is having continuous discharge. It's wet. It's having, even serous sanguineous discharge. And later on, you observe that there is pus as well. Okay, so, and you're dressing it every day. Would you call that sepsis or a septic focus? Okay, just sepsis. Okay, so I have an answer. Yes, very good, Usha. You've got the point. You will call any infection in your body, a sepsis or a septic infection when it has some systemic manifestation. Suppose because of that wound, there is tachycardia. Suppose because of that wound, there is fever. These are systemic manifestations of a local, point of infection. It is a septic foci. Definitely it's a septic foci. It's a confirmed infection at one particular place, but still it does not have any systemic manifestations. It's still localized in that area. The macrophages, the leukocytes, the inflammatory response of the body is, just localizing it, and it's not letting it spread to the bloodstream and to the entire body to cause any systemic manifestation. That means neither the patient is tachycardic, nor she's having fever or a swinging pyrexia, whatever it is. She's not affected. It's a small thing, a small entity which is localized because of the body's immune response. That's only an infective foci, still not sepsis. Agreed? The moment you have a systemic manifestation, it's called as sepsis. Okay? So sepsis is defined as any infection or an infective foci along with systemic manifestations. Correct? Now, what is severe sepsis? Severe sepsis along with sepsis-induced organ dysfunction or tissue hypoperfusion. That means now you're going a step further. Some system has got involved. It could be any system. And you're having tissue hypoperfusion. Maybe the BP is going down. Maybe the patient is going in for... Now, severe sepsis means that she's having either anuria, kidney is involved. She's having tachypnea, lungs are involved. She's having generalized body dysfunction, hypoperfusion, hypotension. These are all severe sepsis. Okay? These are all manifestations of severe sepsis. And the same thing will become a septic shock if, because of this persistence of hypoperfusion, despite adequate fluid. Now, I have taken charge. Now, I'm giving her a lot of fluids. I'll be telling you exactly how much fluid is to be given and how to manage that. How much to be given, initially, and then how to maintain the dose. Basically, this is the persistence of hypoperfusion despite giving this. So if you start giving them externally the fluid, she should be fine. But she's not fine. She's still having a lot of hypoperfusion. That means she's going in septic shock. And what is the mortality rate of septic shock? We just studied 60%. That's right. Now, symptoms of sepsis may be less distinctive in the non-pregnant population and are not necessarily present in all cases. Now, that's the worst thing. The maximum level of negligence and medical legal comes from patients who have gone in sepsis. So the patient came to you repeatedly after cesarean section that, I have fever, I'm having fever. And you're like, okay, just take this antibiotic and you'll be fine. And she's like, I'm not fine. I'm still having fever. Okay, fine. You change the antibiotic, now have. You don't even ask her. Once she comes to you and goes back, she might come in such a bad state that you might need her to put in the ICU straight, and her relatives are going to be furious at you because she came to you before and you did not take her seriously. Even with a small thing like Mesitis can land her into the ICU. So today, going back, you have to vouch to yourself that anybody post-op, especially post-op. Why do I say post-op? Because these people will never forgive you. They'll say, you did something in the surgery because of which my patient died. Suppose if it goes to that level. Okay. So especially post-op patient, normal delivery patient also you have to take seriously, but especially post-op patient, you have to take it double seriously, because fever for us is like, oh, reactionary yoga is fine. Just take paracetamol, you'll be fine. If I've already given you the antibiotics, you'll be okay. But fever can be because of multiple things. It could be because of MRSA also. You've given antibiotics which are covering most of the organisms. That chart also I'm going to discuss with you. But it's not catering to that particular organism because of which the patient is feeling so sick. And by the time you start taking her seriously, she's ended up in ICU. And by the time ICU people have taken over, she has deteriorated so fast. It has happened with so many patients. Thankfully not my own patient, but I've had a experience of working in so many different setups that I've seen these kind of cases. Not a lot, but yes, I have. So they just deteriorate very fast, especially those patients with lower socioeconomic background. Anyways, so what my the purpose behind telling you all this is that you have to take these people, these patients very, very seriously. So if you vouch today that anybody who comes to you post-op with swinging pyrexia, with low-grade fever, even that patient has to be interrogated properly, and I'll tell you how. That's going to be my next upcoming slides. So this I want you to have a very good look at, and I don't want you to fumble in at least this aspect after tonight's class. SIRS. How many of you have heard this term before? I think it must have been asked in your exams as well. Yes. I've seen so many question papers. I don't know exactly which one in your DNB exam it had some university question paper. So SIRS has come before, right? So how many of you knew about it, and how many of you knew confidently about SIRS before? What all are the 4 important things that you have to see in SIRS? First of all, temperature. Okay, temperature 100.4 and more. Right, and at the same time, I always talk, whenever we talk about sepsis, we always talk about hypo or hyperthermia. So above 100.4, less than 96.8. Okay, respiratory rate more than 20, WBC count either more than 12 or less than 4,000. Correct. PCO2 less than 32. So that means partial pressure of carbon dioxide also you have to see. SPO2 nahi, PCO2. All right. At least 4 things are very important. We've been always taught about these 4 important things. This is SPO2, CO2. This is for your examination point of view. But yes, for these 4 signs, you'll be able to pick up very fast. WBC, obviously, you'll send a CBC, right? Whenever the patient comes to you who's having pyrexia, you will send a CBC. But heart rate, respiratory rate, temperature, you can see in one go. Correct? So even if there are 2 such features of SIRS, along with a confirmed foci of infection, see, confirmed or suspected infection, she goes in sepsis. Right? Severe sepsis when one of the end organs is involved. That means either there is hypotension and especially lactate level is increased. Correct? Now, septic shock means I'm talking about such severe sepsis, along obviously with the signs of end organ damage, when there is extended going on hypotension despite measures to correct hypotension, despite fluid support. Correct? She's already gone in septic shock. So who are the ones who are increased risk of sepsis? Even if you just close your eyes and don't forget about puerperium, just talk about in general, what kind of patients are at a high risk for sepsis? Close your eyes, answers will start coming in. Low socioeconomic background, anemic patient, diabetic patient, malnourished patient, obese patient, a patient who already had a history of pelvic infection, patient with a very morbid surgery, Verdyme or modified radical or radical hysterectomies. They are usually the ones who got a longer duration of operation, this extensive surgery, the ones who got usually a drain and a catheter and everything inserted in them. So these are the candidates for sepsis. So you have to watch out for those patients who had extended surgeries or who have long operating hours of surgery, a patient who was already having some focus of infection, a patient who did not do very well, and anemic patients who in which you had to give blood transfusions. These are all candidates for sepsis. So I did not go reading that entire list because that was only for puerperium, because this guideline is actually for puerperium. But these lists, of patients who can undergo sepsis is very, very obvious. Now, what are the microorganisms which can cause sepsis in puerperium? This is very important. Now I'm talking specifically about puerperium because as far as puerperium is concerned, there are certain very specific organisms which are going to hit. Otherwise, E. coli hits, staph, strep, they are very, very common. But puerperium, you have this gas that is, this group A, group alpha, streptococcus, which is specifically streptococcus pyogenes. Okay, group beta, you have beta hemolytic streptococcus is different with this group A, right? So you have, apart from that, of course, you have E. coli, staph aureus, staph pneumoniae, MRSA, very, very important. This is that organism which will give you the problem, okay? Because you are giving an antibiotic which is, broad spectrum antibiotic, and they are not going to help if the patient has got MRSA. She's going to keep deteriorating till you realize it later on. So why am I specifying gas over here? Is because that is the organism which is mostly associated with puerperal sepsis. And otherwise, if you're talking about sepsis post-op, well, these are the other organisms. So you have E. coli, very, very common, mostly inhabiting the drains, the tubes and everything. Klebsiella is very, very common. Staph, strep, and of course, MRSA. Now, this is over. Now let's talk about what are the likely causes of sepsis outside the genital tract. Is definitely important, right? Your patient is just delivered. She's going to have 1,000 kind of bacteria which can enter because of the dilated and open cervix. But apart from that, she's going to have what else apart from genital tract? What other organisms? From where are they going to hit the patient? So you have to talk. And you have to, just take out the history from that patient. If you feel that this patient, needs to be treated properly, you need to have a proper history. And why am I saying that? Is because of this. See, Mesitis is the one which I want to tell you. Mesitis, urinary tract infection, pneumonia, skin infection, gastroenteritis, pharyngitis, they are all likely causes of sepsis other than the genital tract. So you have to look for signs and symptoms and focus of infection apart from, of course, a cesarean section scar or a local lochia that you keep seeing, or just palpating the uterus that no, it's not tender, it's not subinvoluted, it's fine, so she's okay. No, very important history of mastitis should not be overlooked. Why? Mastitis leads to breast abscess. Breast abscess usually isn't colonized by, till the time patient comes to colonized by MRSA. Okay, it has happened with me. One of my not patient delivered with me. She delivered somewhere else, and she came to me with breast abscess. And I took, the first thing that I did was to send that pus for culture. But during her course of treatment, she forgot to bring that report. She forgot to collect that report, and I was treating her on and on. And there's so many patients, you forget to ask a patient their report unless they come and show you the report. You forget to ask them, and she's being treated and every day. My sisters are doing the dressing, and she's not healing properly. And one day it happened that she went absolutely low, and then the second day she came back with more pus. After drainage, okay, I'm talking about after drainage. It's a long road to recovery for breast abscess, let me tell you that. So after drainage, she came back with more pus, dressing with more, the granulation tissue had come and everything. And the next day she came with a lot of discharge. Then she got me the report, and I was, so surprised that she's having MRSA, and we were treating her with clavin. That is not a thing, this amoxicillin, ampicillin, they will not help in recovering from a MRSA infection. What antibiotics should be given to a patient who's got this MRSA infection? Can anybody tell me that? First of all, please give me the full form of MRSA, anybody, and then give me the antibiotic of choice in MRSA infection. Okay, I've got the second answer first. Now, quickly tell me the full form. This everybody should answer. Come on, guys. Everybody should answer this question. I wanted more participation, and I want everybody to be, awake in my class, because of which I'm asking such silly questions. You should be able to answer everybody. Yes, Geeta, good. Come on, guys. Okay, apart from vancomycin, is there any other antibiotic that works very well with MRSA organisms? Vancomycin is there, yes. Okay, very good. Very good. What else? Teicoplanin, yes, very good, very good. So teicoplanin is the one which is a very good antibiotic, and that works with methicillin-resistant staph, and where you do not have ampicillin and amoxicillin, they do not work there. All right. So you have to be very, very sure of what you're treating. Mastitis happens to be very important. UTI, if she's having, signs and symptoms of UTI, be sure to aggressively treat it, because then it will lead to acute pyelonephritis in no time. And then you'll have, restriction on giving the antibiotics also, because most of the antibiotics, they will be excreted through the kidney, and kidney is already compromised, correct? Then you have pneumonia. You have to look forward for a focus of pneumonia. Hemoptysis usually would not have, but yes, if you do have, you have this problem of treating pneumonia. Skin, soft tissue infection, yes. That's your, stitch site infection, correct? So the stitch site infection, any other local skin infection, like over here, necrotizing fasciitis, okay, that can occur. That's got horrible cases. Usually now it's by, what do I say, our strict asepsis protocol and strict antibiotic regime. Such cases of necrotizing fasciitis, at least they're not very common in the hospital environment I work in. I do not know what is the current status of SSI in your government hospitals, but before this I was in one of the trust hospitals. A lot of workload was there, and every next few days there was an SSI. All right, so yeah, I mean, a lot depends upon the environment in which this patient goes after surgery, tight dressing or not, and then clean beds or not, clean sheets or not, clean blankets or not, then at home what is her status, and above all, most important is the surgical scrub technique, the surgery, the surgical place, the technique of surgery, and the OT environment. Correct. Now, you have, the moment there is a stitch site infection, please don't forget to take the swabs. Even if you put the patient on antibiotics, be very sure that you have collected the swabs. Correct. Now, we have seen the signs and symptoms. Correct. We've talked about the way to go from there. We've talked about those sites which you have to have a good eye on, from where to collect what samples. For example, there's a history of, let's say, Mesitis. Start the antibiotic. Flucloxacillin happens to be a very, very good antibiotic for treating Mesitis. Suppose she's got into, abscess. Just go in for drainage for little pus and send it for culture. If suppose there is a stitch site infection, collect the swabs of pus from there and send for culture. She's having UTIs and urine for culture. You think she's having diarrhea with foul smelling diarrhea, please send the stool for culture. So you have pneumonia, if you're suspecting that, sputum for culture. So you've taken you've got this suspicion of sepsis or septic focus in the patient. You've taken a proper history from the patient. Obviously, you've started managing the patient in terms of the signs and symptoms that she came with you with. You've taken a proper history. You've sent the samples. Now you've placed the patient on IV antibiotics, broad spectrum, awaiting the result of these samples that you sent. Correct? What should prompt the recognition of sepsis in the puerperium is very, very important. What things should you keep an eye on and take this patient up seriously? So there are certain clinical signs which are suggestive of sepsis. I told you about pyrexia, I told you about hypothermia, tachycardia, tachypnea, hypoxia, hypotension, oliguria, impaired consciousness. Very, very important, and most important, failure to respond to treatment. All these things the patient came with. You started an antibiotic and the next day she's much better than she was before. That's the step ladder you want to see. You do not want to see that, oh, nothing, I'm still the same or deteriorating. You never want to see that, because the person who is deteriorating despite admission and all these, and you've got her late. Okay, and she might not respond. Right? That is the usual answer. Of course, the signs which pyrexia. Now, very, very important thing I'd like to tell you over here, that clinically speaking, see, I'm talking all these things to you. You feel that how can anybody miss a patient with so many things? But what happens basically in practical life is, when a patient is actually going in sepsis, the signs are so subtle. Sometimes pyrexia is also not there. Either it is there or very low-grade pyrexia is there. How many times have you taken up a patient very seriously, admitted a patient just because she came to you after puerperium with mild fever? You haven't. Even I haven't. But reading all these things now, we realize that, it's 2-3 extra admissions are better than ignoring one case. Correct? Do not ignore. Keep a strict check on the patient, because by the time she'll come back to you again, she must have deteriorated far beyond, the scope of immediate management and immediate well-being. Okay? And you don't want that. Not on your watch. Mastitis never should be overlooked. Abdominal pain, fever, tachycardia, all these are indications for IV antibiotics and a senior clinical review. So the moment the patient is with pyrexia above 38 degrees, tachycardia more than 90, you have to take her up into the hospital. Okay, and obviously give her anybody whom you're giving IV antibiotics has to be hospitalized, right? Now, NSAIDs should be avoided. So you start with paracetamol, you keep her on paracetamol only, you're giving her, and why do we do that? Why is it avoided? Because they impede the ability of the polymorphs to fight the infection, especially the gas infection. Okay. Here is the answer. They impede the ability of polymorphs to fight the infection because they're anti-inflammatory, correct? Now, again, I have spoken so many times about the common symptoms of puerperium: diarrhea, vomiting, breast engorgement, rash. Yes, Streptococcus, Staphylococcus. They are the ones who produce rash in the body. Abdominal pain, pelvic pain, tenderness, wound infection, vaginal discharge, productive cough, urinary symptoms, delay in uterine involution, heavy lochia, foul-smelling lochia. All these are the common symptoms of sepsis with which the patient will come to you. You do not have to miss the signs which he's showing or the history that you could have taken out from her, and you would have started from there, the journey, correct? Now, what is the optimum way to monitor the patient? Now, what you did was that she came to you with symptoms, you saw her signs, you took her up seriously, and now you're monitoring her. You've admitted her, now you're monitoring the patient. So what is the optimum way to monitor the patient with suspected sepsis? Abhi tak we are there only. We have sent her culture, and I'll get to that also, okay, what all you have to send. But right now you are suspecting sepsis in this patient. You've admitted her, so you've started giving her IV and fluids, and you've started giving IV antibiotics. And IV antibiotics, you've started some broad spectrum antibiotics. Correct? Abhi, I'm not going into the diagnostic modality. Abhi, I'm just asking you how to monitor this patient. You've admitted this patient now, right? So first of all, a multidisciplinary approach is very, very important, okay? And a consultant-led unit has to be there. Senior obstetrician to be involved, okay? And then, of course, this team includes the microbiologist, the infectious disease expert, the intensivist, okay? You have to monitor her according to, obviously, you have to go for a temperature charting, pulse rate charting, blood pressure charting, respiratory. These are 4 very, very important things. You cannot underestimate it. 4 of them are features of SIRS. You have to have a, blood pressure, the temperature, the respiratory rate, and the pulse rate. Very, very important. This should be recorded in a Muse chart. How many of you know about the Muse chart? I think I spoke in some lecture of mine about the Muse chart. And I did not get a proper chart, but I think I gave you the idea of what Muse chart is and how to use it. So I just want to know from my students over here, I don't want to ask you exactly what Muse is. I just want to know whether you have an idea of Muse chart. How many of you know about the Muse chart? I'm not going to ask you. Just tell me how many of you know about Muse chart. And suppose if I ask you a question exam tomorrow, let's say a 5-mark short note, Muse chart, would you be able to answer that or not? How many students I have in the class? Guys, come on. You need to at least write down yes or no, right? Write down no or yes. Okay. Yes, good. See, I like the honesty, I don't know much. That's fine. I'm here to teach you. I'm going to teach you accordingly then. All right. Okay, good. What about others? They're so silent. There's neither yes or no. What about them? Just 4 or 5 students answering. They're all my usual students, all of them, who always answer. All right. So let me just tell you what Muse chart is. Okay. So this Muse chart, first of all, now you know the background. So patient has come to you and suspected sepsis. You are monitoring her, correct? How do you monitor this patient and what all are included in the Muse chart? This is the Muse chart. I'm sorry, it's from the net, and because of which maybe it's not very, very clear to you, but I'm trying to make it a little more easy to understand. The important variables: temperature, as you were expecting, systolic blood pressure, again, you were expecting, heart rate, expected, respiratory rate, expected, and SpO2 rather than SpCO2, correct? And the level of consciousness. So 1, 2, 3, 4 already then SIRS. SpO2 already was there. CO2 was there. Level of consciousness. These 2 have been added, you can say. And it's got zones, the green zone, the yellow, the orange, and the red. Look at the scoring, 0, 1, 2, 3. And before we get into the detail of all of this, just have a look here. The Muse score. So 0 to 2, they say, you can reassess the patient in 12 hours. This is a low risk patient. She's not going to deteriorate fast anytime soon. And you can just, maybe look at her after 12 hours. You just continue charting her for this particular variables, but you can do that at a lesser frequency. Vis-a-vis a patient who goes into the zone of 3 and above, you have to assess her in 2 hours, okay? And every time you have to change the grading of news. Suppose she's now going into the safer zone, 0 to 2. Put her back to 12-hourly monitoring. But till she's back into that safe zone, you have to keep seeing her every 2 hours. You have to see whether, this temperature is going in the normal, usual zone or not, the regular zone or not, or it's pyrexia to the patient, to the systolic blood pressure. See, if it's going beyond 200, if it's going above, 200, or it is in the normal range. Heart rate is going above 100. Respiratory rate is going above 20. 20 above is like we already told you that is SIRS. SpO2, anything which is greater than 96 should be normal. Otherwise, it could be dangerous. Level of consciousness, she's alert is okay. But if she's not alert, there are 1, 2, 3 categories, especially the third one in which is unresponsive. Correct? So 1-3 zone, 1-3 score, and she's already in the danger zone. So this is Muse. If you just remember the variables that you're seeing in Muse, if you just remember the 0 to 2 and 3, and if you know that this is the kind of monitoring that you have to do along with 0 to 2 score and 3 score, you know that Muse score is the one to look forward to finally monitor the patient, whether she's going in the healthy direction, she's becoming normal again, or she's going in the other direction where she's circling the drain, we call it. But that means she's going in the other direction in the sense she's becoming bad to worse. These are the patients to watch out for before they finally enter into that zone in which there is no return. Correct? So this Muse score is going to tell you about all that. Now, what infectious disease history or information should be noted? So over here, I don't know. This is not a very important slide. It's just an information that you can ask from the patient. Suppose there is no specific focus of infection, then you can ask her regarding her travel history or anybody in her neighborhood who was also ill. Okay, and if she's had any such food from outside, which could be a local cause of infection, or the infection might develop in the days to come, she's already having some some signs and symptoms. Then you can call her if there was anybody who was also ill along with where she's living or staying. So these things you can ask. This is the history that you would want to elicit. Now, what are the important triggers or features of sepsis in the puparium that should prompt hospital? Now, there's a patient whom you'd regard as in sepsis. All such patients will not be admitted, correct? Yes? All such patients are not going to be admitted. Only a few of them will require hospital admission. So you think what could be the red flag symptoms which can cause admission in the hospital for a patient? So patient who comes to you with a pyrexia of 38 degrees and above. So patient is coming, I'm having a swinging pyrexia. It happened with one of my patients. Okay. So she went back home and she's like, I'm getting fever off and on again. So when your patient calls you and says all this in India, you call most of the patients, they come to you, I am having fever. It's not recordable on the thermometer, but I'm feeling feverish from inside. Now, whether to take this patient seriously or not, because every next patient says that. And more so in the government hospitals and government setups, because they're this thing of saying, that I'm feeling feverish from inside. They will get rid of their work. Everybody's going to say, okay, oh, fine, she's not okay. Let her go and rest. In the same time, there's nothing to prove. I'm feeling feverish from inside. Nothing's being recorded on the thermometer. I'm not fine. Mostly it talks about those patients who are not feeling absolutely okay. This is their expression of telling you that I'm not totally all right. So swinging pyrexia will not be given admission, but pyrexia sustained at 38 degrees and more should be admitted. Tachycardia more than 90 should be admitted. Breathlessness, admitted. Abdominal or chest pain, admitted. Diarrhea, vomiting, uterine angle pain, renal angle pain, women generally unwell, or she looks unduly anxious, please take her in. It's like I said, 4 wrong admissions are much better than 1 case fatality. Correct? Now, just one, I'm trying to just impress upon you the fact that early presentation of sepsis in less than 12 hours. What usually is the cause of that? Strep infection, streptococcal infection. Okay, so particularly the gas with severe continuous pain, usually suggesting necrotizing fasciitis. The speed of onset of deterioration and symptoms and signs is very, very important, because any patient who's rapidly deteriorating is already gone on the path to no return, mostly. So early treatment with antibiotics, oral or parenteral, that's very, very crucial. Abdominal pain, tachycardia, very, very important. In hospital, high dose intravenous broad spectrum antibiotics should be started immediately without waiting for the results of investigation, because once infection becomes systemic, the woman's condition can deteriorate extremely rapidly, with death ensuing within a few hours. This is what I'm trying to impress upon you guys, that anybody with post-op fever has to be taken up very, very seriously, because they deteriorate very fast. Now, yeah, you can see anybody who's got sepsis, you involve, right from the beginning. People from other faculties always do that. Always involve a general physician. In our case, I'm saying it's going to be a general physician, but in other places from where these guidelines are coming, they usually have an infectious disease panel. They have a microbiologist who's seeing the swabs and who's making the slides, and who's doing the culture tests. So involve that person, early on in the disease, not after she's already deteriorated.